بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. The second session of the last day of this great conference will be given by a well-known international speaker, Dr. Khalid Al-Sais, who is an associate professor, Department of Radiology, University of Texas, Anderson Cancer Center. He's a professional lecturer and author of many research studies that have been published in national and international scientific journals. He will give 3 lectures, important lectures for practicing radiologists. The first one is state-of-art differential approach of focal hepatic lesions on CT and MR. The second lecture is international multidisciplinary classification of HCC. And the last one is hepatocellular carcinoma, impact of Milan model for end-stage liver disease. Please, Dr. Khalid.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. It's my great pleasure and honor to be here around you, and it's a great pleasure specifically to be in the Medina, the city of Prophet Muhammad sallallahu alaihi wasallam, where the da'wah, Islamic da'wah, has spread to the whole world. Thank you very much, Dr. Muslih, and thank you for all Saudi people, my people, for inviting me to give some lectures here. I will start by MRI of focal hepatic lesions, and we'll try to comprehend this topic in diagnostic approach to see how we can reach a precise diagnosis for focal hepatic lesions. So first, this is the MRI technique used for diagnosing focal hepatic lesions, and we always make sure that we have mix of fat saturated and non-fat saturated T1 and the T2 weighted imaging. And so for non-fat sat, we have non-fat sat T1, we have chemical shift in phase and out of phase, and then we have dynamic pre and post contrast, specifically in the arterial, venous, and delayed phase. And T2, you have also non-fat sat single shot fast spin echo on GE, and what's called the haste on Siemens. And you have short-term version recovery as fat sat T2. I'm not going to go in depth with the technique because I'm sure that most of us are aware of the technique. I'm going to go directly into the focal hepatic lesions, how we can differentiate between them based on enhancement pattern and pattern recognition approach. So if we're going, I hate really to mention the focal hepatic lesions based on pathology, because based on pathology, I'm going to tell you that we have congenital lesions, and all of these are congenital: infection, inflammatory, vascular, benign neoplasm, malignant neoplasm. So we have more than 100 diagnoses with the focal hepatic lesions. Rather, I tried to come up with approach based on imaging, and I divided these into groups, and this is the first group. And I would like you to take a look at it and tell me what do you think. This is number 1, number 2, number 3, and number 4. And to go quickly through these cases, this is number 1, which is a simple cyst, and this is characterized by low signal intensity on T1 weighted imaging, high signal intensity on T2 weighted imaging, and no significant post-contrast enhancement, and this is a simple cyst. So first group is simple cystic lesions, and what does this mean? If you see one simple cyst, it can be just simple cyst. And by simple cyst, I mean there is no enhancement of the wall, there is no complex septations, there is no solid components. So, so this is number one, and this is the most common hepatic lesion, is simply a simple cyst. It's better characterized by MRI because of its definite signal intensity and contrast, and no contrast enhancement. And as I said again, should not enhance and should not have any complexity such as thick wall or solid components. Number two is also multiple cystic looking lesions throughout the liver here, and by MRCB you see them communicating with the bile ducts. So this is Caroli's disease, which also appears on cross section as multiple simple cystic looking lesions. And you see in the middle of such a cyst, you see enhancing dot here, which is that's what's called central dot sign, and the enhancing dot is coming from the parallelly running portal radical, which is getting grabbed by the cystically dilated biliary ducts. And this is Caroli's disease, and it's autosomal recessive. These can present to the ER with a triad of right upper quadrant pain, jaundice, and right upper quadrant pain, jaundice, and fever. And so this can lead to biliary stasis and formation of calculi. It's autosomal recessive, and also it has a significance which is predisposing to cholangiocarcinoma. So case number 3 is typical for what it is, which is autosomal dominant polycystic kidney disease. You see multiple cysts scattered throughout the liver, and you see here obviously scattered in both kidneys. You see fluid level, and which is indicative of hemorrhage within this cyst. Hemorrhage is very common in the setting of autosomal dominant polycystic kidney disease. It does not predispose to cancer. So this is again a known case of autosomal dominant polycystic kidney disease. Case number 4 is biliary hamartomas, and this is also appears as multiple sub-centimeter cystic looking lesions scattered throughout the liver. As we see here on MRCB, it does not communicate with the biliary tree, which is a differentiating feature from Caroli's disease, which is the more concerning disease. So this is the group number 1, which is simple cystic looking lesions. And again, simple cyst, if a single, it can be also multiple simple cysts. Caroli's disease, cystic lesions or cystic dilatation of the biliary tree, which appears as cysts on cross-section. Biliary hamartomas are sub-centimeter, non-communicating with the biliary tree, and autosomal dominant polycystic kidney disease. This is a group number 2. Diagnosis. I need to revert again to the females here and males here because they will answer all questions. So this is a case number 5. This is another case number 6. Case number 7. This is Dr. Yusuf Qathi case. Case number 8. Case number 9. And the case number 10. What's the diagnosis here? And I know that all of you will get this diagnosis right here, especially Abdurrahman. So the second group of lesion, as you can tell, it's complex cystic lesions, either by complexity, presence of septations, presence of abnormal enhancement. But in this case, these lesions are predominantly cystic with some complexity. So the case number 5 here is biliary cyst adenoma. And biliary cyst adenoma is benign and malignant cystic tumors of the biliary origin, which may arise in the liver. You see them as multiloculated and can be filled by mucinous fluid. Most important here is to tell me, when you read this case, such a case, is tell me how much enhancement is there, how much solid component is there, is the septation thick or thin. So because the thicker the septation, the higher the malignant potential, the more presence of solid component, the higher the malignant potential. So all of these are, even the literature, they don't say cystadenoma, they say cystadenoma / adenocarcinoma because of the high malignant potential of this, and this is where come the importance of diagnosing such cases and the follow-up of these cases because of the high malignant potential. If I have such a case, I would like it to be resected. Case number 2 is an abscess, which appears also as septated cystic mass with some surrounding enhancement, as you see here in the parenchyma, which is secondary to hyperemia, secondary to the infection. And abscess, this can be biogenic or amoebic abscess, and the case number 7 is also multiple abscesses. This case was shown in a Saudi board, and as you see, multiple lesions, multiple complex cystic lesions in the liver. When you see multiple, would it be pyogenic or amoebic? It would be pyogenic. And this is, when you see abscess, you need to actually look for a source of infection. And here there was a source of infection within the right colon. So there was right colitis and ascending abscesses to the liver. So here, when I diagnose abscess, I need to differentiate between amoebic and pyogenic abscesses. Amoebic tends to be in the right hepatic lobe and tend to be single. Pyogenic tend to be multiple and scattered in both hepatic lobes. The case number 8 here, and you can tell this by the signal intensity, that it's high signal intensity on T1, high signal intensity on T2, some septations. This was complex hematoma to the liver, secondary to prior trauma. Again, it appears as septated cystic appearing mass in the liver. This is a cystic lesion in the right liver with some enhancement, some perilesional enhancement. When I see something like that, I need to put abscess definitely in the differential diagnosis. But here, I need to ask about previous procedure, because that's how exactly appears like the radiofrequency ablation cavity looks like. And this is normal post radiofrequency ablation within the first 3 months of radiofrequency ablation. It's very important when I diagnose radiofrequency ablation cavity to know whether this is normal or abnormal. This is normal because, as you see, it's a homogeneous, linear enhancement, no nodularity, no solid component. And it's also important to review the T1, pre-contrast T1, and the T2, because if there is any recurrence within this cavity, it would be low signal intensity contrasting with the high signal intensity of the coagulative necrosis on T1, and a low signal intensity on T2, which is also compatible with the signal intensity of coagulative necrosis. So this is radiofrequency ablation. This is typical for what it is, which is echinococcal disease or hydatid cyst. You see multiple daughter peripherally oriented like cysts within a larger cyst, which is the mother cyst. This is hydatid disease or hydatid cyst. This is typical for what it is. And then you see here also another case of hydatid or echinococcal cyst, which is characterized by floating membranes within the larger cyst. So when we talk about complex cystic lesion, our differential will be biliary cystadenoma, abscess, cystic metastatic deposit, hydatid disease, organizing hematoma, post-radiofrequency ablation. I mean, to me, not the most common in the differential here, cystic metastatic deposit, but it's most significant. I need to really rule this out by the presence of, if there is primary tumor, specifically GEST or mucinous cyst adenocarcinoma, it can lead to cystic metastatic deposit, which can exactly look like cyst, especially if this patient is on Gleevec therapy. So cystic metastatic deposit is a significant diagnosis that I don't need to miss here, and can look exactly like complex cyst with abscess. So you can see how can I rule out the different diagnoses here. So my job as a radiologist was to mention the differential diagnosis and say what is this most likely to be, and according to the presentation or according to some lab values, according to the history. So here abscess can be ruled out by the clinical presentation of the patient: fever, right upper quadrant, recurrent pain with some leukocytosis. Cystic metastatic deposit can be ruled out by the absence of primary tumor, specifically GIST and mucinous cyst adenocarcinoma. Hydatid disease has a typical appearance of multiple mother cyst with multiple daughter cysts within it, and also they can have some elevated laboratory values, and it can appear in endemic areas. Organizing hematoma tend to have history of prior trauma, or the patient has bleeding tendency, and then it follows the signal intensity of blood, so there is no way that I can actually mix it with other things. And we need to ask about the history because you don't want to make diagnosis abscess while it can be just radiofrequency ablation cavity. The third group here, what's the diagnosis here? What's the diagnosis? حد يقول هنا؟ أنا عارف sometimes there is no hope in a certain group, so what's the diagnosis? Okay, أنا شادة هناك بتتكلم. So this is another case. What is this? And this is a third case. This is a fourth case here. This is another case. And this is another case. So what's the third group of lesion here? I showed here what? Arterially enhancing lesions. And when I talk about arterially enhancing lesion, what's the most important thing you evaluate? What's the most important thing you mention here? أهل المدينة, I give them this several times. Cirrhosis. So the most important thing to comment on is the cirrhosis, presence of cirrhosis, because cirrhosis will tell you what's the order of your differential diagnosis. So the differential diagnosis here is the same, but you just need to reorder it to look smart or to actually look accurate, because you cannot be accurate if there is a patient has cirrhosis and you don't tell me the top diagnosis here is HCC. So HCC, you need to diagnose about it until proven otherwise in the history of cirrhosis, or not history of cirrhosis, actually the full outflown features of cirrhosis you have here. So the most important thing you evaluate when you have enhancing focal hepatic lesion is the presence of cirrhosis. And when the presence of cirrhosis, HCC is always the top diagnosis in the presence of cirrhosis. What about non-cirrhotic liver? What's the order of your differential diagnosis? Would you include HCC in the diagnosis, in the differential? Yes, I would include it, because it can appear, or it can actually form on top of non-cirrhotic liver, but I put it in the bottom of my differential diagnosis. I put first focal nodular hyperplasia as the one that has highest incidence in the liver as a benign lesion. If non-cirrhotic, it would be likely benign more than malignant. FNH would be top. Flash filling hemangioma, I need to think about it. Adenoma, as also I need to think about it, especially with women with oral contraceptive. And the hypervascular metastases, and then HCC. And there is a specific condition where HCC can arise on non-cirrhotic liver. What is this? Fibromyalgia definitely can occur on non-cirrhotic liver. Hepatitis B, actually. Hepatitis B, when you see a patient with hepatitis B, non-cirrhotic liver, you may think of the development of hepatocellular carcinoma. So this is the order of your differential diagnosis in non-cirrhotic liver. You need to think about FNH, adenoma, flash filling hemangioma, hypervascular metastases, and HCC. And actually here it comes the role of the recent hepatocellular agents or hepatobiliary agents such as Eovest or Primovest. You inject the contrast, it will be excreted, will be retained by hepatocytes, excreted in the biliary tree, and you can differentiate between metastatic deposit, which does not uptake Eovest or hepatocellular agents because it doesn't have hepatocytes, and something like FNH, which retains the Eovest. So and it's also, again, you think about the case, and you have thought process about this case, and you put your differential diagnosis. And one of the most important things that you need to rule out here is the malignancy, the hypervascular metastases, and you rule out by hypervascular metastases by ruling out the primary tumor. Still, there can be primary tumor which you don't see, but at least the absence of primary cancer would put it in the top or on the bottom of the list. Okay, so hypervascular metastases, what sort of primary tumors? You think endocrine, so you think thyroids, pheochromocytoma, islet cell tumors in the pancreas. You think also of renal cell carcinoma. So it is a known group that can lead to hypervascular metastases in the liver. Adenoma, usually in a woman with oral contraceptives, FNH, can have central scar. The majority of these lesions have central scar, but still, if you see enhancing lesion without central scar, you still put FNH in the top of your differential diagnosis. And as I said, HCC can occur on top of non-cirrhotic liver in some conditions such as hepatitis B and also such as fibromyalgia carcinoma. First diagnosis here was hepatocellular carcinoma. You see here cirrhotic liver with enhancing focal lesion. This is HCC on top of cirrhotic liver. And then commonly alpha-fetoprotein here is elevated. I mean, there are some exceptional conditions where you don't see alpha-fetoprotein elevated, which I will tell you also about when we go through the rest of the lecture. And it's very important to get the constellation of findings to get together. So with HCC, it's arterial enhancing, but it's washing out in the delayed phase. As I said, cirrhosis is another thing, and pseudocapsule can also can appear in the delayed phase as enhancing. And also, it's very important to differentiate in between various nodules that can be seen in the liver on top of cirrhosis. So you have regenerating nodules moving to this plastic nodule HCC, and most pathologists think that HCC arise in a stepwise fashion. So it starts from regenerating nodules, moving to these plastic nodules, moving to HCC on top of this plastic nodule, moving to small HCC and large HCC. What's this case here? So we see here arterially enhancing lesion here next to the gallbladder, and it's faintly enhancing, but still there is bulge and there is enhancement here, as you see. So we asked here for MRI, and MRI demonstrated this as a very high signal intensity like fluid on T2. So what is this diagnosis? Flash filling hemangioma, and you were able to make this diagnosis based on MRI pulse sequence, MRI signal intensity. You can actually rule it out now. You can actually say this is flash filling hemangioma, full stop. I don't need to follow this. I don't need to do anything with it. So this is something that you can take it out by means of a very bright signal intensity like fluid on T2. So this is the second diagnostic possibility here, and this is sort of a typical presentation of hemangioma. It occurs in hemangiomas less than 2 centimeters, so it has to be small. And basically, it's just, hemangioma is like a sponge. So if this sponge retains fluid or contrast, early on it will appear as arterially enhancing. And the way to differentiate the hemangioma between hemangioma and other lesions is to look as T2 signal intensity, which is typically high signal intensity on T2. This case is a reminder for you that, if you see multiple lesions, arterial enhancing lesions in the liver, you need to analyze every one of them separately. So you have here 2 lesions, as you see. This lesion is arterial enhancing, retaining contrast in the delayed phase, which again is a feature of flash filling hemangioma. It retains contrast in the delayed phase. The other one looks like a flower here. More centrally, it becomes intense in the delayed phase. And on T2 here, if you look at them, this one has a very high signal intensity. So what is the diagnosis here? حد يتكلم بقى يا جماعة عشان خاطر بس. Flash filling hemangioma, right? The other one, however, you don't see it at all on T2. This is typical for what it is, which is focal nodular hyperplasia. And again, the liver here is non-cirrhotic, so this is number 1 that you look at. And then the diagnosis here would be this one would be FNH, and this one would be flash filling hemangioma. Both of them are benign entities. Again, here non-cirrhotic liver looks smooth here, and you see multiple arterial enhancing lesions, and lesions here wash out on the delayed phase. And this patient has history of carcinoid tumor that sent some hyper enhancing metastases to the liver, as you can tell. Multiplicity is another thing that you look at, because multiplicity would be more favoring hypervascular metastases, and you need to rule it out. And again, as a reminder for you and myself, EUVEST or hepatobiliary agent like Primovest here in the Middle East, that's what the commercial name, can be helpful in the diagnosis of metastases, because these metastases will tend to be hypo-intense on Primovest, like 20 minutes phase of Primovest, which, because it does not contain hepatocyte, does not retain the contrast, and will appear as hypo-intense on 20 minutes phase of EUVEST. And as I mentioned, those are common primaries that can lead to hyper enhancing metastases, like neuroendocrine tumor, renal cell carcinoma, breast, melanoma, thyroid, pheochromocytoma, islet cell tumors, carcinoid. Those are the most common ones. What is this case? This is a woman with oral contraceptive history. Some of you, and I heard this before, say, okay, this is washing out, so it's HUC. No, other lesions also can wash out, like adenoma can wash out. And this case was adenoma. The liver is non-cirrhotic, the lesion is arterially enhancing, and it's washing out on delayed phase. This was hepatocellular adenoma in a woman with oral contraceptive. So as you can tell, you can actually seek the help of some laboratory values. You can seek the help of history too, to help you out diagnose. Also, in non-cirrhotic, I wouldn't start by malignancy, I would start by benign. Non-cirrhotic liver would be more likely to be benign, although malignancy cannot be excluded. This lesion is also arterial enhancing. It's large. It has here a faint hyperintense area of high signal intensity on T1, and does not enhance this area, as you see here. And this area again here does not enhance. The lesion itself arterially enhanced heterogeneously, and then it fades out in the delayed phase. And this was hepatocellular adenoma. Whenever you see a hemorrhage within arterially enhancing mass, especially in a woman with a history of oral contraceptive, you need to think about hepatocellular adenoma. What is this? This is another group of lesions that can mimic arterially enhancing lesions here, although this is a hypodense lesion in the liver, but there is area of which hyperenhancement here secondary to it. Well, and this area become isodense on the delayed phase. احنا هنخلي شهادة تتكلم بس. ولد شهادة توك. What is this? So what is this? Yes. And what is that? That's difficult. You didn't see this, Shada, so you're not. ايه؟ حد يقول حاجة. It's difficult. This is difficult case, but. And what is that? So I'm showing here some, again, fourth group of cases where you see arterially enhancing lesions. These lesions are not really, one of these groups of lesions we talked about. It's arterially enhancing. Still, the wedge-shaped area of enhancement here, I would talk about THAD, transient hepatic attenuation difference. Okay, with this wedge-shaped area. This is a different entity though. This is a metastatic colon, metastatic deposit, this hypodense. But what happened is that this colon metastatic deposit occluded a branch of portal vein that lead to this wedge area of hyperenhancement that become isodense on the delayed phase. So this is a colon cancer metastatic deposit with THAD, or transient hepatic attenuation difference. This is same entity, but on MRI we call it THAD, which is transient hepatic intensity difference. And so it was always actually confusing me when I was still resident. How come there is an element of portal vein occlusion and you see hyper enhancement? And this is how it comes from. This is the dual blood supply of the liver. You see here most of it from the portal vein, and 25% is from the hepatic artery. So what happened when this is Mr. Metastatic deposit? What happened when Mr. Metastatic deposit occlude the portal vein? Actually, hepatic artery takes over and leads to this gush of blood to this wedge-shaped area, and this is an area of wedge-shaped hyperenhancement secondary to occlusion of the portal vein. So now we understand the mechanism of it. But it's worth mentioning that you will see a lot of these in the liver without a cause. Actually, the most common cause of THED or THAD, transient hepatic attenuation difference or transient hepatic intensity difference, is idiopathic. It's just no cause for it. It's just you see it and it comes and goes. But when you see it, you really need to. When you see it, you have to rule out underlying branch of portal vein thrombosis. So this is transient hepatic attenuation difference. The third case here is hot quadrate sign or hot spot sign. Here you see an area of hyperenhancement in segment 4 of the liver. This is typical for what it is, which is hot quadrate sign secondary to enhancing collaterals from, you see the collaterals here enhancing on the anterior abdominal wall, and this is exactly like what Dr. Hassan said. This is secondary to superior vena cava thrombosis. You see a large tumor here occluding the superior vena cava, and see some collaterals in the anterior abdominal wall. This is something that you need to rule out. You know, in the American board this year I failed somebody because he said, I'm gonna biopsy this. This is because, you know, he has here, this is a vascular element. It's not a neoplasm. So we need to watch for this. We need to be careful not to misdiagnose with other tumor. This is what's called apparent gastric venous drainage, and you see here an area of patchy area of hyperenhancement in segment 2 of the liver. But you see this, what is this? That's a branch of gastric vein, that's left gastric vein draining it. And similarly here, this is right gastric vein draining another lesion here. And believe it or not, we're in MD Anderson, and still radiologists misinterpreted this as an area as renal cell carcinoma metastatic deposit, and I would make this misdiagnosis if I'm not aware with this entity, and that's why I'm showing it apparent gastric venous drainage. And this, you see, hyperenhancing pseudo lesion in the liver typically appears around the falciform ligament, typically in segment 2 or segment 4, as we see here. If it's apparent left gastric vein, it will be segment 2. Right gastric vein, it will be in the segment 4. And the typical, it appears, it occurs because of the abnormal communication of the portal vein with the gastric veins. If I see a mass lesion like this, I will have to be concerned, and all of us will be concerned. You see an irregular hyperenhancing mass lesion in the liver, but really, in the absence of any hepatic disease, in the absence of any, abnormal findings, laboratory or clinical findings in this patient, there is an entity which can occur, which is called the inflammatory pseudotumor. And the inflammatory pseudotumor, again, I need to consider it. If the patient is completely normal, you might just need to take a biopsy from it and prove that this is not malignant, especially with non-cirrhotic liver. I will have to be concerned if I see something like that. Really, the standard of care that I will see, I'm not gonna be a hero and say inflammatory pseudotumor, but I will think about it as one of the differentiating diseases here. So I would say this is, it could be malignant, but there's an entity called inflammatory pseudotumor. It's a rare entity that can occur in the liver, and you can give it a shot, you can give it a biopsy, and this is proven to be inflammatory pseudotumor, which is a rare benign process, most commonly involving the lung and orbit. You remember the pseudotumors that you see in the orbit, and you still need to differentiate between it and other things. This is the same inflammatory entity characterized by polymorphous inflammatory cells and variable amount of fibrosis, and that's what you see in the pathology. You will look like a hero if you make this diagnosis, at least if you say, consider biopsy here in this case, because the patient doesn't have any underlying diseases. Could be this entity, and it will be actually it will be like Eid for the patient if it's diagnosed as inflammatory pseudotumor rather than a disease like HCC. I showed this multiple times before, and this is another case. So this group of cases is characterized by the presence of central scar, and here the main differentiating entities between entities here are focal nodular hyperplasia and fibromyalgia carcinoma. You see this one, this is fibromyalgia carcinoma. You see this lesion here as high iso-intense signal intensity within the liver on pre-contrast. On T2, the same thing, and the central scar here is low signal intensity still. But here with FNH, the central scar is high signal intensity. You see this lesion, how it's nice, it's like a flower. Okay, it's very homogeneously enhancement. With fibromyalgia carcinoma, it's irregular, as you see, ill-defined, and it's heterogeneously enhancing. The central scar here does not enhance early and does not enhance late. With FNH, the central scar enhances. And you really think about the pathologic, background and pathogenesis of this lesion. What the central scar is like in FNH, what central scar is like in fibromyalgia carcinoma, and you differentiate between them. For that, the fibromyalgia carcinoma central scar is fibrous, so it will be low signal intensity on T1, low signal intensity on T2, does not enhance arterial, does not enhance delayed. However, if you wait long enough, our standard protocol does not include the 10 minutes delayed phase. If you wait long enough, it will be enhancing, okay? But with FNH, it does enhance in the delayed phase because it's like a conglomerate of blood vessels, okay? This conglomerate blood vessels appears as stagnant blood, low signal intensity on T1, high signal intensity on T2, does not enhance early, but enhances on delayed phase. So this is a central scar of focal nodular hyperplasia. This is another group of lesion, which is a nodule within a nodule. You see here a cirrhotic liver. There is an area of hyperintensity here in the liver on T1 pre-contrast. And there is another area which is developing on top of it, which is low signal intensity on T1. It's arterially enhancing. This is nodule within a nodule, and it is indicative of HCC arising on top of this plastic nodule here in this case is with cirrhosis. And again, it will be very nice to catch this early. If you catch this early, it will have an excellent prognosis. So nodule within a nodule is indicative of HCC on top of this plastic nodule. Here, that's what's called the peripheral washout sign, and this was described by Dr. Ahmed Imad Mahfouz. And you see here this mass lesion, which is not really enhancing, it's heterogeneously enhancing, faintly enhancing, but the way I would really describe it as hypo-enhancing compared to the liver. However, in the delayed phase, if you wait long enough, there is this area of hypointensity at the periphery of the lesion. Actually, this is a sure sign for malignancy. If you see this peripheral washout sign or this low signal intensity in the periphery, this is a sure sign for malignancy, specifically metastases, and it has been described specifically with cases of colon cancer metastases. Peripheral washout is the name is given by Dr. Ahmed Mahfouz. Is not very accurate name, because in this case, in such case, it does not wash out, it rather fills in centrally, leaving this low signal intensity in the periphery. But he actually did a great job in just describing this finding as a sure sign for malignancy. If you watch for this, you will find it actually more often than what you would be ignoring before. So this is again a colon cancer metastatic deposit. Look at this case here. This is almost hypoenhancing compared to the liver. Then you see this peripheral area of hypo density in the periphery here within this lesion, indicative of colon cancer metastases. So peripheral washout is a sure sign for malignancy. This is another group of lesion. You see here an regular lesion that is hypointense on T1, hyperintense on T2, and then it starts to fill in the delayed phase. So these lesions, this group of lesions, demonstrate delayed enhancement. So this is a case number 1. Case number 2 here is a mass here in the central of the liver that, you know, keeps retaining contrast in the delayed phase. What's the diagnosis here? And this is another case that's well circumscribed. Early on it's hypo intense, then it shows peripheral nodular buddling. This peripheral nodular buddling demonstrates central filling in delayed phases, and this is typical for what it is. What's the diagnosis here? Very easy. And this is a case of, you see some capsular retraction and hypo intensity and pre-contrast is still hypointensity in arterial phase, and it demonstrates delayed enhancement later on. See, this is actually the problem. This is this is not cholangiocarcinoma. This is retractile fibrosis of cirrhosis. And this is a case here. I remember Shada got 50 riyal. I still remember this 50 riyal. Yeah, I give 50 riyal in the past because Shada made this diagnosis, and I need this 50 riyal back from her. So this is a very rare case, which is biliosis hepatis, and it's characterized by confluent areas of low signal intensity on T1, high signal intensity on T2, and it demonstrates delayed enhancement here. This is biliosis hepatis. It's very rare. I wouldn't even recommend that you focus with such a diagnosis. This is case number 1, which is colon cancer metastatic deposit. The reason I'm showing this case, and I showed this case in the Saudi board the last year, the reason I'm showing it is almost every resident, when I start to show this case, say it's hemangioma, just based on the delayed enhancement. No, actually, specifically colon cancer metastatic deposit can demonstrate delayed enhancement or centripetal extension of contrast like that. And if you really compare between this and between hemangioma, this lesion is very ill defined, is very irregular, as you see, and then the enhancement here is continuous. Okay. So it's a completely different pattern from hemangioma, and you need to actually raise this concern in such cases with primary colon cancer. So because colon cancer metastatic deposit can demonstrate delayed enhancement, and you don't need to ignore this. And when I also focused after this with a lot of cases, I found that, you know, this is actually a common feature for colon cancer metastatic deposit, that it demonstrates delayed enhancement, delayed filling in the delayed phase, as you see here in such cases. Believe me, even wallahi in MD Anderson, I've seen some colleagues who are even expert that can miss the diagnosis of this. They can say, okay, this is sclerosing hemangioma. That's not true. This is a colon cancer metastatic deposit, and you need to raise this entity in such cases. So this is again the group, and this is a case of cholangiocarcinoma that typically demonstrates delayed enhancement. It's a solid lesion, as you see, and you see it centrally or peripherally or even extrahepatic, and it's commonly characterized by this delayed enhancement. This is a case of typical hemangioma, and it's typical for what it is. It's low signal intensity, well circumscribed mass lesion, peripheral nodular buddling, and centripetal extension of contrast in the delayed phase. Very high signal intensity on T2, and all of these are consistent with hemangioma. This is retractile fibrosis of cirrhosis, and it can actually mimic the diagnosis of cholangiocarcinoma. You need to raise this possibility, especially if you see it in the anterior segment of the right hepatic lobe, and this is again typical for confluent fibrosis secondary to cirrhosis. biliosis hepatis. This is a very rare case, and it demonstrates some areas of delayed retention of contrast. And the biliosis hepatis is very rare disorder, and you see the small sinusoid, the 3 millimeter sinusoid, dilate, and they can actually coalesce together to form masses like that, and it's very uncommon, and it's seen in chronic wasting due to TB, cancer, and drugs, including anabolic steroids. This is another group of lesions. So this is hypoenhancing mass lesion, and I see another one here. It demonstrates some faint hyperintensity. Look at this here. It's not like the fluids. It's not like the CSF. It's just hyperintense, and it's hypoenhancing in the post-contrast phase. This is another case which is hypoenhancing. It's wedge-shaped, and it's actually peripheral, and see in the liver. This is another entity which is similar. الله يخليك صورني جنب السلايد. طلعني في الصورة يعني. So hypoenhancing areas here, and which is scattered in the liver. This is also the same entity, or similar entity, which is multiple hypoenhancing masses in the liver. And this is another different case, which is multiple hypoenhancing lesions seen scattered in the liver. So again, this is the 9th group of lesions, and when I think of hypoenhancing lesions, I should have put this earlier on the lecture. This is hypoenhancing lesions. I need to think in a group of diagnoses. Most important of them is hypovascular metastatic deposits, which was the case here. And again, it arises in a group of cancers such as like lung, prostate, and the colon. Those are all characterized by hypoenhancements, or they do enhance actually, but they enhance less than the liver parenchyma, or they appear hypoenhancing compared to the enhancing liver parenchyma. This is how it is in the T2. It's faint area of hyperintensity on T2. Those are hypovascular metastases. Those wedge-shaped areas of hypoenhancement in the liver, or those looks like vascular insults like ischemia. Ischemia is very rare in the liver. That's why when you see this, you need actually to correlate it with underlying actually cause for coagulation, such as HELP syndrome, because the liver has dual blood supply, so it's not common that the liver develop ischemia, but they can develop ischemia in such cases of shock, trauma, HELP syndrome, like in a postpartum woman with hemolysis, elevated liver enzymes, and low platelets. Again, you correlate with the clinical factors. You'll be like, and you will see that this is actually can be easily misdiagnosed, and most of us even can overlook such cases, while if you can just look up the laboratory evidence of elevated liver enzymes and low platelet, you can make this diagnosis, and you can look really smart. This is a known case of lymphoma, which is characterized also by multiple hypoenhancing areas in the liver, as we see here. And you make it in the context diagnosis of lymphoma. When you see multiple small hypoenhancing, hypointense lesions scattered throughout the liver like that, you need to think of inflammatory entities such as microabscesses, such as candidiasis, fungal or bacterial microabscesses. You can also think of granulomatous infections such as sarcoidosis among the differential diagnosis of such hypoenhancing lesions. And you need not to forget about cirrhotic liver nodules, regenerating nodules, if it's hypoenhancing. If it's not enhancing, it's good, because this can be benign cirrhotic nodules such as regenerative nodules, which you need to consider. Here, such a case of low signal intensity foci in the liver, cirrhotic liver. This is T2, this is T1, and those are not enhancing, those are regenerating liver nodules. So this is a group again of hypoenhancing lesions, and you need to think of metastases, lymphoma, infarction, infection, granulomatous inflammation, benign cirrhotic liver nodules, and very important also is to think about focal fatty infiltration and how would you narrow this down. I'll show you how to narrow this down in the next case. So again, here the clinical will help you. We're not, some people, some other clinicians think we're photographers. We're not photographers. We are clinicians too. We need to correlate with the history. We need to correlate with the labs. We need to correlate with the clinical manifestation. So if a woman presenting postpartum and you do the lab, she's in a bad clinical condition, laboratory evidence of high liver enzymes and the hemolysis and low platelets, I need to think about HELP syndrome. If the patient is having lymphoma, I need to think of lymphoma as an entity. If the patient has lung, but it's very important also, this hypo-enhancing metastases and the hyper-enhancing metastases is very important to put in consideration. I remember just last week I was staffing a case with a resident and there were multiple hyper-enhancing lesions in the liver, non-cirrhotic liver. The patient has a primary history of cancer, but this cancer was colon cancer. So it doesn't fit together that colon cancer can lead to hyper-enhancing. No, it doesn't fit together. So I told him, really? I mean, you think of colon cancer metastatic deposit. This is not colon cancer metastatic deposit, I can tell you, because this just doesn't go with the pathogenesis of these metastases. Those are hyper-enhancing lesions. You need to have this thought process. So I told him, number one diagnostic possibility here will be FNH. We bring this patient back. We give the patient AUVEST or hepatocellular hepatobiliary contrast agent. The hepatobiliary contrast agent was retained by the liver by these lesions. It diagnosed to me FNH. So actually, the patient was so happy. The clinician was so thankful, and the resident learned something here that they need to have the thought process. And then you need to think of benign cirrhotic liver nodules as part of the differential diagnosis. Focal hepatic with focal fatty infiltration. I will tell you in a minute how you diagnose it. What is this? This is a very atypical manifestation, but again, with the thought process, you will reach a specific diagnosis. Here, you see, this is T1, but this is what? Out of phase. This is in phase. Do you see these multiple hypointensities here in the in phase? I don't see them. What about here in the post-contrast? I don't also see them. I see rather some normal vessels traversing through these. So what are those? Focal fatty infiltration. Areas of focal fatty infiltration. Does it look typical? It's not typical because it looks really like metastatic deposit, and that's why it was referred for MRI. It looks really multiple hypoattenuating on CT. It looks like multiple hypoattenuating in the patient with breast cancer. I have to be concerned about it. I really need to raise a flag here. And okay, so MRI was further recommended, and by MRI you can see that these lesions all demonstrate signal drop on out of phase compared to in phase. Well, this is how I diagnose intracellular lipid on MRI. In CT it's difficult because intracellular lipid can look like any hypoattenuating mass. It doesn't look like a cyst. It's just hypoattenuating solid mass. It's not really a mass because it does not exert any mass effect. You see normal vessels traversing through it. It does enhance like the normal liver. So this is diagnosed as areas of focal fatty infiltration. What is this? This looks like a mass. But again, this is in phase, out of phase. You can tell out of phase by the low signal intensity, surrounding these solid organs. You don't see this low signal intensity here. This is a mass containing intracellular lipid. You need to think of adenoma. So adenoma is characterized by the presence of intracellular lipid, and you can actually, with constellation of finding hyperenhancement, with constellation of some laboratory evidence or a clinical history of a woman with oral contraceptive, I need to narrow down the differential here to hepatocellular adenoma to be on the top differentiating disease. What is this? This looks like a liver. This liver is in other areas. I also see it's cirrhotic. It's somewhat nodular, but I see this lesion here. This lesion demonstrates an area that's hyper intense here, that demonstrates signal drop out on out of phase. This is again out of phase. You see this low signal. See the good delineation of the liver here and solid organs. This line which is surrounding the liver on out of phase here. You see the drop out of signal on out of phase compared to in phase. I need to actually think of HCC with fatty metamorphosis, and I need to put also the other, bulk sequences and the post contrast enhancement with it together to make the diagnosis of hepatocellular carcinoma. Also, you can look at the alpha fetoprotein correlated with this too. So this was HCC containing fatty metamorphosis. So here again, I look at lesions containing intracellular lipid, and I diagnose intracellular lipid again by means of in phase, out of phase. Let's go back to this. By means of in phase, out of phase. This is out of phase again. Let's review it quickly. When you see this low signal intensity line surrounding the solid organs compared to this in phase, you don't see this low signal intensity line. You see these lesions drop in signal intensity on out of phase compared to in phase. I make here the diagnosis of focal fatty infiltration in the liver. It's, as I said, those are not mass-like lesions. You don't see any mass effect for those. And again, a typical pattern is you see normal vessels traversing through them. But I cannot make the diagnosis of focal fatty infiltration here, although I see drop out of signal on out of phase compared to in phase. So a mass lesion containing intracellular lipid, and it's homogeneous like this with non-cirrhotic liver, especially with oral contraceptive history, I think about hepatocellular adenoma. It's going to be the diagnosis until proven otherwise. And on the other hand, this is like this actually fat is more heterogeneous, is like different from the other the previous case. And in a patient with cirrhotic liver, I need to think about HSC with fatty metamorphosis. I need to correlate it with the other bulk sequences with the post contrast enhancement to make diagnosis of HCC. There are two more groups to go here, so I need to think of. So the previous group was a group of HCC with fatty metamorphosis. So this is a different group. What is this group like? So those are multiple lesions. You see here that these lesions contain foci that almost looks like the intra-abdominal fat. So this is not intracellular lipid. It's now macroscopic fat. Macroscopic is like Abdul Khaliq showed them your belly. It's like the subcutaneous fat here. It's like the subcutaneous fat. It's not like the intracellular lipid. It's not like the lipid that you see at the cellular level. And that's why I always make these two distinct entities. You don't tell me this lesion contains fat. This, I hear this worldwide. I hear it even in America a lot. I don't like containing fat. I don't like it. I can declare I don't like it. I like saying intracellular lipid or macroscopic fat, because those are two different entities with two different differential diagnoses. Here I see multiple macroscopic fat. It's like the macroscopic fat here is like the macroscopic fat here. So multiple mass lesions containing macroscopic fat. But if you look at the mesentery, you see also this primary mass and containing also intracellular, not intracellular. See, I made the same mistake. Containing also areas of macroscopic fat. This was liposarcoma, sending metastases, multiple metastases to the liver. So those are multiple metastases containing macroscopic fat. And I see it here again in the coronal reformatted image. It's not a very common thing, so I don't think of this up front. I don't think of metastatic lesion containing macroscopic fat, because macroscopic fat containing lesion is benign in the liver until proven otherwise. Benign like what? Like what we'll show now. This is another lesion here. So can we analyze it? Can one of us analyze it? Yes, we can analyze it. So on MRI, you look now at the fat sat bulk sequence compared to the non-fat sat. You remember in the intracellular lipid, we were looking at in phase, out of phase. Here we look at the fat sat and non-fat sat compared to non-fat sat. This is fat sat. The lesion here, the small one here, suppress in signal intensity on the fat sat, indicating macroscopic fat containing mass lesion. This is lipoma. And I don't need to do anything about it. I don't need to biopsy. I didn't need to do anything about it. It's pathognomonic for what it is. This is just a small lipoma. And you see here some India ink artifact on this out of phase compared to in phase, and it does not enhance like what you see here in the non-fat set or the fat set post-contrast T1. So this is lipoma. This is a very rare case. I'll tell you the diagnosis right away because it doesn't actually, we don't need to tire ourselves with very rare diagnoses like that. This is what's called hepatic adrenal rest tumors. A mass lesion within the right hepatic lobe has multiple areas of, like negative attenuation. It's negative attenuation on CT, like the intra-abdominal fat here. If I do MRI, I would look at the fat set pulse sequences. I compare it to non-fat set. I see dropout of signal intensity within this. These foci. This is hepatic adrenal rest tumors. If I see this case, I would say probably angiomyolipoma. Actually, I would say that that's more common than hepatic adrenal rest tumor. So what's the differential diagnosis of lesions containing macroscopic fat? So first we diagnose macroscopic fat by the presence of negative attenuation on CT, by the drop or the suppression of signal intensity in fat set compared to non-fat set. So the diagnosis here, differential diagnosis will be lipoma, angiomyolipoma, metastases. This is a rare thing. Secondary to primary containing macroscopic fat such as liposarcoma and HCC with fatty metamorphosis. Yes, it can also contain macroscopic fat less commonly than the intracellular lipid. And this is the last group of lesions. I see here multiple calcified lesions in the liver. Very important to know that cancer such as mucinous adenocarcinoma can send calcified metastases to the liver. So calcified lesions, I need to put this is a concerning differential diagnosis. Always have your mindset to the malignancy and try to actually exclude it. Yes, don't do it, don't put it in the top of your differential diagnosis, but you have to consider it, because if you miss it, you're gonna look bad. And this is multiple calcified mass lesions, and these were actually treated mucinous adenocarcinoma metastatic deposits. This is the differential diagnosis of calcified liver masses. You need to actually think about them. A significant portion of them are benign, including some granulomatous infection and vascular entities. But you have here, I need to consider mucin-producing neoplasm from the ovary, stomach, colon, and the breast, or primary malignancy such as intrahepatic cholangiocarcinoma, or infection inflammatory, which is more common, granulomatous infection. Thank you for your listening. خلينا نخش على طول بقى، ما نضيعش وقت. هيبقى نص ساعة. اوكي، خلينا بس مركزين يا شباب، الله يكرمكم. احنا هنعمل حاجة سريعة جدا. هحاول I'll try to get it in 10 minutes. بس it's like a appetizer. صحيح, it doesn't taste good, but in 10 minutes very important to know about it, and then we'll move to a different topic, and then afternoon there is 30 minutes session. Well, I'm presenting this because wallahi I'm eager to even give the science before it gets published. So this will be published soon. I'm publishing this soon in radiographics. Within a couple months it will be shown in the radiographics how really we stage HCC. It's very important to know this topic, and the reason for that is staging of HCC is different from any other tumor. Other tumors are commonly staged by TNM system. Used to use TNM system with HCC. Okay, but now if you think about it, how much of HCC are treated by surgery? TNM is a good pathological staging system when surgery is desired, right? But how much of HCC is treated by surgery? It's only 20% of HCC are treated by surgery, and that's why people came up with other staging systems. I will go through them very quickly to just give you the taste of it, and then I advise you to read about it, because it's important when you read the case of HCC, it's important to mention some aspects of it as you know, as staging for this tumor. You don't tell them this is stage whatever, but you know exactly what it represents. So TNM is not a very good staging system for HCC, because only 20% of HCC are treated by surgery. So people needed to come up with some different, you know, pathological system. So people from Spain came up with Barcelona, Italy came with Clip, and French, and then China came up with Kubi, and then Japanese. There is another system for Japanese. So we'll go over them very quickly, and we'll mention what's the most important one of them. So this is the background of HSC. All of us would know about it, like for the prognosis and, you know, incidents and all of stuff like this. So I need to go over it. And again, this is staging and scoring systems, and those are the new ones that has developed. Most important of them is Barcelona staging system. So this is the TNM system, and the TNM is like TNM of other tumors, and here the diagnose T0, T1, T2, and T3A, T3B, and T4, and we'll mention them. We'll go over them very quickly. And as you know, like any tumor, you mentioned the size of the tumor, you mentioned the invasion of vascular invasion, and the direct invasion to adjacent organs, regional lymph nodes, and metastases. So TNM, tumor node and metastatic deposit. And this is T1, which is a tumor less than 3 centimeter, no vascular invasion. This is T1. This is T2. This is tumor which is solitary and with vascular invasion, or there is multiple tumors less than 5 centimeter with no vascular invasion. So it's either one with vascular invasion or multiple without vascular invasion. And then this is multiple tumors over 5 centimeter. This is T3A, and this is multiple tumors larger than 5 centimeter with vascular invasion, like what we see here in the portal vein. This is T3B. And then T4 is like the metastatic, or the lesion with direct extension to other organs, here to the duodenum, here to the peritoneum, and here you see to the pancreas. So we see here peritoneal metastatic deposit. This is T4. So it's very important when you diagnose this, again, in your report, to mention vascular invasion, to mention, any extension. And most important here, which can be easily measured, is the peritoneum, extension to the peritoneum, because it moves the lesion. There can be a small lesion here that directly invade to the peritoneum, and instead of being T1, it can be T4. So those are all aspects that you mention in your report. And then with the nodes, you mention the regional lymph node, and then metastatic deposit, you mention any metastases, okay? Then there was this need of coming up with a system that consider really some aspects that the radiologist may not think about it, and it's more important because clinical here is very important for the patient to be considered for a specific treatment route. So here 3 parameters were developed in addition to the tumor size, which is less or more than 50%. Here, so they consider ascites. So by us, what we need to do, we need to say, okay, this is less than 50%, more than 50% of the liver, in addition to the presence or absence of ascites. And for the labs, they need to tell us about the serum albumin, and they need to tell us about serum bilirubin. So there is a limitation here for OCODA, which again, as I said, first system to include liver function tests. It's effective of identifying patients at advanced stage OCODA, stage 2 or 3, but it's not effective in early stage. And early stage for us is very important, is of paramount significance in the diagnosis. So OCODA system is limited in identifying patients with early disease. Okay, so if we give some point system here, as we said again, so ascites, bilirubin, and albumin, and you need to give them based on that. You give 0 if there is no ascites, you give 0 if the albumin is less than 3, you give 0 if the the bilirubin is less than 3, you give 0 as if the albumin is more than or equal to 3, and you give 0 if the tumor is involving less than 50% of the liver, and then you add these points together. No points is stage 1, which is very early disease, good prognosis, and then point 1 or 2, this is stage 2, and then stage 3 or 4, this is stage 3, which is 3 or 4 points. Okay. So if we really give this, what point we'll give here? Would we give 0 or 1 here? Would give 1 because it's more than 50%. And would we give 0 or 1 here for ascites? We give 1. Okay, that's how we add it together, and then albumin, and then tumor size, then albumin, and then bilirubin, and then you add this together, and to come up with this point system for Okuda staging system. The early stage has a good prognosis. The latest stage or advanced stage has a poor prognosis. What about cancer of the liver Italian program? They come up also with a system that combines tumor-related features like tumor extent and morphology and serum alpha-fetoprotein and presence or absence of portal vein thrombosis. So here, as a radiologist, you need to tell them about, tumor extension, if it's uninodular or multinodular, and you need to tell them about portal vein thrombosis. And again, they come up with point system. And very important here that they consider child poo stage. Child poo is something for to indicate the severity of cirrhosis. So they add some lab value together and they come up with a staging according to child poo to say this is severe cirrhosis or mild cirrhosis, and then they add it to like other diagnostic features to come up with a point system, and this is also very well considered system. But Barcelona, I'm asking Abdel Khaliq. Well, Mishana is not here. Riyab, absence. Okay. Abdel Khaliq is one of the most prominent radiologists in Medina. We know him since he was the first year. If I ask him about Barcelona, what Abdel Khaliq will tell me? Messi. Messi is a great player in Barcelona. And Abdel Khaliq will tell me, okay, Barcelona clinic, liver cancer. Okay, Messi. This is Messi, the player for Barcelona. This is El suit. Yesterday he was actually given the best player of the world, and بدلة غريبة جدا. We have a singer like called Shaban Abdurrahim, and he actually dressed exactly like this, and I wish there is a man suit like this. Anyway, so Barcelona clinic liver cancer. This is the most actually practical BCLC, the most practical staging system for the staging HSCC, and it's very well considered worldwide. And again, what do we do with this Barcelona? It's very important for us to say it's uninodular or multinodular size of the tumor nodules, vascular invasion, extrahepatic spread, and portal hypertension. They add this together with some laboratory values and some other parameters to come up with early, whether it's early stage or intermediate or delayed stage. And again, very important for them, child poo system. Child poo does include a lot of factors that they added together, and they give classification based on this point system from 0 to 6, and they give it A, B, C. Performance status, and the performance status is very important. You're not gonna get a patient who is going to buried in Baqi', and tell him, okay, before you die, let's do liver transplantation or something. So performance status is very important, and it's very important not only in HSC, but it's very important to be considered. If the patient is almost dying, why bother give him an aggressive treatment? So you actually, we do a very early stage, and then early HSCC, and then intermediate, and then advanced, and then you make this calculation together, and this is the performance status. And as you see, 5 is like that. So there can be a patient who's almost dying, and then you find a doctor giving him a very aggressive treatment. So it's here, it's given very early stage, intermediate stage, advanced stage, and terminal stage. And as you see here, the diagnosis here is based on a lot of factors. I told you child poo, which includes a lot of liver function, and performance test, which includes like how the patient generally perform in life, and then some imaging size, tumor size and extension, vascular invasion and stuff like this. You add this together to come up with these stages: very early, intermediate, advanced, and terminal stage. With terminal stage, you just give palliative care, as you see, okay? But early stage, you might consider ablation, or resection, or liver transplantation. There are some certain, route for each of them. If the patient is very early stage, meaning that it's a single lesion less than 2 centimeter, child who is still very early and performance status is 0, which means very good, you can say that this patient is a potential candidate for liver transplantation. If he is potential candidate for liver transplantation based on a lot of other considerations. If it's not potential candidate for liver transplantation, you can just do ablation, radiofrequency ablation. If it is potential, you look at portal pressure and bilirubin. If they are normal, you can do resection. If they are increased, look at associated disease. If there is associated disease that precludes liver transplantation, you don't do liver transplantation. Again, you do ablation. But if there is no associated disease, you can do liver transplantation. With intermediate stage, you can consider chemoembolization, transarterial chemoembolization. But with advanced stage, portal invasion, extrahepatic spread, you can consider sorafenib. Sorafenib is anti-angiogenesis medication that's given to this subset of patients. If terminal stage with child debut and performance status is almost dying, you can just give the patient palliative care. It's very important. This is just to broaden our mind. For radiologists, very important. Again, we're clinicians, so we need to broaden our mind to know that there are several factors that play in place and added together to for the differential diagnosis. So to me, it's very important that the radiologist, and then if there is advancement of disease, what you do. You can give chemoembolization, you can give radiation. We also in MD Anderson we give radiotherapy in addition, and we give sometimes combined chemo and radio embolization, chemoembolization. Okay, so we need to be aware of these staging systems and put it in place. Sorry for being very fast going through it, but it's just giving you the concept of what these staging systems means and how to put it together for the best management of the patient. Okay, I'm gonna move to the third lecture, and then we're getting another session afternoon. Post-operative diagnostic workup of orthotypic liver transplant. Impact of recent advance of cross-sectional imaging. So you do liver transplant, and you need really to follow this up intimately by imaging and to see how this imaging play a part in the diagnosis of various complications. So what's the modality of choice in post-imaging workup of liver transplant? Ultrasound, actually, and ultrasound Doppler. Okay, so those are the learning objectives for our lecture. Review surgical procedures and altered anatomy for liver transplantation. Review the current diagnostic workup and utility of various imaging modalities. Discuss pertinent finding associated with orthopic liver transplant complications. Those are the indications of liver transplant: cholestatic cirrhosis, non-cholestatic cirrhosis, metabolic disease, acute hepatic necrosis, malignancy, and that's the only malignancy that can be treated by HSC, is the only malignancy that can be treated by transplantation. And then other diseases such as graft versus host disease and cystic fibrosis. There are some contraindications here that you need to consider and put in place. So if there are some extra hepatic malignancy, you cannot do liver transplantation with orthotypic with extra hepatic malignancy. If there is some cholangiocarcinoma, cannot be treated by liver transplantation. And HSCC not meeting Milan criteria, and we're gonna go over what Milan criteria is and what does it mean. Also a contraindication if there is infection, advanced cardiopulmonary or neurological disease, active drug or alcohol abuse, anatomic abnormality. You can you do a liver transplantation in a patient who's dying, who's having severe cardiopulmonary or neurological disease, who's having drug or alcohol abuse, because he's gonna keep on this after doing transplantation, is gonna be useless. So what are Milan criteria which are established for optimal results for orthotopic liver transplantation patients with HCC? So those are for specifically are criteria for patients with HCC, and it tell you when to do liver transplantation, when to avoid it. So the tumor, if the tumor is unifocal and under 5 centimeter, you can do it. If you have multifocal tumors, less than 4, like 3 or less, and less than 3 centimeter each, you can do liver transplantation, provided that there is no extra hepatic tumor. So there are some listings. So they do the patients came to them. They actually prioritize this these patients, and they prioritize the patient according to 2 systems: United Network for Organ Sharing, which is actually they put the donor with the recipient together, matching, and they come up with point system according to the matching criteria, according to medical criteria, including MELD, which is model for end-stage liver disease. It's called the MELD score, and the blood types. So they put MELD score and the blood type together, like to check the compatibility of the blood groups and stuff like this, and they put it together to kind of prioritize these patients. So and they come up with a score system, and the liver is given to the patient with the highest score. What's the MOLD, which is MELD, which is the other with the other system that's used for listing liver transplantation? It's a model of end-stage liver disease. Again, there are only limited number of donor livers. You need to prioritize the patients according to certain criteria. These criteria, again, a lot of the laboratory values are playing a part here in this staging or listing score. Serum bilirubin, serum creatinine, and INR are the main parameters for this MELD or model for end-stage liver disease. Again, let's go into action now. Imaging of liver transplantation. We have ultrasound, CT, and MRI are the main diagnostic modalities for imaging of liver transplantation. We'll look into each one of those and play together with the specific complications. Ultrasound is the cost-benefit effective, and also it's more practical, it's more available, it's more convenient for the patients and for the doctors. It's non-invasive, no ionizing radiation, but it has some disadvantages. CT also has high sensitivity and specificity. It guides for intervention. CTA provide an excellent tool for diagnosing the vascularity and vascular integrity. It has some disadvantages. So I really prefer MRI for any liver imaging. If we have something that's shown by ultrasound and need to refer it for further imaging, it would be MRI, because of the many advantages of MRI, like multiplanar capability, high contrast. Yes, we have multiplanar capability in CT, but this one has a better tissue characterization, no ionizing radiation, and you still can have MRA, MRCB in place, and you can characterize the tissue, you can characterize the fluid collections, you can look at the biliary and portal vein integrity without even contrast. And there are some disadvantages that we are all aware of the MRI in general, but you need some time interventional radiology to intervene with some cases, like with some vascular and biliary cases. Those are our algorithm. This is our algorithm for imaging workup. So you start by screening by ultrasound. So what if it's normal? You don't do anything else. But if there is if it's normal with high clinical concern, you proceed according to the clinical concern. So if there is a vascular suspicion, you do MRA or CTA, in addition, of course, to the parenchymal evaluation. If there is a biliary suspicion, you definitely do MRI with MRCP. And if there is a parenchymal suspicion, I would say here MRI in addition to CT. Both of them can be good. And then again, if they are abnormal, if the arterial vascular integrity is abnormal, so you need to the interventional radiologist to intervene with that. And then if it's normal, you just do routine follow-up. So what are the complications to start with? So you think, in addition to the fluid collections that can be there, like fluid collections can be hematoma, abscess, lymphocele, seroma. All of these can be in the arising liver transplant, for which you may do some stuff. Like if you see fluid collection, also the injection of hepatobiliary contrast agent. Hepatobiliary contrast agents such as Eovest is excreted in bile. So in 20 minutes you can be able to tell whether this is a biliary extravasation like biloma or other fluid collections. Okay, so this is another thing. But there are some other complications that arise from the vascular tree, from the biliary tree, or from the parenchyma, which will go over them. So first, you need to look at the vascular integrity, and you need to be aware of how we perform the liver transplantation. So they can do it directly end to end, like this, end to end, common hepatic to common hepatic, or they can actually have a conduit. And they have a conduit. It makes sense that if the hepatic artery is diseased, you don't do it for the liver transplant. You rather use a conduit to connect the common hepatic artery of the donor liver, through a conduit to the aorta or to the actually the what's remaining of the common hepatic artery too. So you can do it end to end directly, or you can do it through conduit, and this conduit can be aorto hepatic, like direct to aorta, or viscerohepatic. So you can do the donor hepatic artery to some vessels like the spleen or other vessels. So what are the arterial complications? What are the risk of them? So most common vascular complications are the arterial complications. Risk factors are many, but you know that when you have too many anestheses, when you have a conduit, you know that this patient is at a higher risk than the patient with only single anastomosis, because you have multiple foci, multiple points that stenosis that can occur at. You can also know that increased cold ischemia time can lead to stenosis more than the the normal procedures. Anastomosis directly to aorta also can also lead to stenosis more than the others. Pediatric patients, technical factors like clamp and stuff. So arterial compromise can initiate a cascade of events leading to hepatic failure, necrosis, graft loss, the biliary ischemia. So you know, all of us, that biliary stenosis, bile duct stenosis, post-transplant, you need to look for hepatic artery stenosis as a cause for it. So number one is hepatic artery thrombosis. This is the most common vascular complication. 10 to 40% of it occur within the first 3 months. So by imaging, you can see actually no vascular flow. This is a portal vein. You don't see a vascular flow within the hepatic artery, and then you see abrupt cut off here on imaging, which is diagnostic of hepatic artery thrombosis. And you see here wedge-shaped infarction, which is a sequela of hepatic artery thrombosis. Hepatic artery stenosis, and for which you need to do a color Doppler on for the hepatic artery. If the peak systolic velocity is higher than 200 centimeter per second, or RI is less than 0.5, you make the diagnosis of hepatic artery stenosis. And again, by imaging here, you can see this area of stenosis in the hepatic artery, as you can tell by imaging. So, but most important is, you can see this tarsus parvus, see this elongated waveform. You see how long it is. It's very long, more than 200 milliseconds. The RI here is less than 0.5. You need to make the diagnosis of hepatic artery stenosis. Also, hepatic artery pseudoaneurysm, it can occur at the site of anastomosis, and they can be often hidden behind the bowel gas, and that can be at the site of angioplasty. So you see just some, focal dilatation of the vessel at this region, and it can result in rupture and fistula formation. Here is a pseudoaneurysm that is a complication of angioplasty, and you see it as yin yang. You see this bidirectional flow within pseudoaneurysm. This is a pseudoaneurysm. With portal portal vein, also the same thing. You can use it as end-to-end, or you can use it through a conduit. Conduit when there is a discrepancy in caliber. Also, this is another indication for conduit for doing like graft interposition. Or if the portal vein, if the recipient portal vein is diseased, so you cut it and you do the graft. So the complications here are rare, and again the same thing. You see thrombosis, you can see stenosis. You diagnose them by ultrasound, and then you can further diagnose them by CT, and you can further also look for some vascular, contrast cross-sectional imaging. So this is, you don't see color flow. This is portal vein through stenosis actually. So you see here very sluggish flow within the portal vein, and by angiography or venography, portography, you see here some stenosis of the portal vein. Portal vein thrombosis, you don't see here any flow within the portal vein at all, which is confirmed by cross-sectional imaging. So those are generally the venous outflow complications. And they can actually diagnose both of them, the vascular arterial thrombosis, arterial stenosis, arterial or venous stenosis, venous thrombosis. The management, you can do thrombectomy if there is a thrombus. You can do angioplasty if there is stenosis within the vessels. And here is a rare case of IVC torsion. And then biliary
Dr. Khalid,
complications.
2 minutes, please.
5 minutes. So we have duku ostomy, where you can actually connect the biliary duct to the biliary duct right away, or you can do it to the jejunum, choledochogynostomy. And again, you can have these complications of biliary stenosis secondary to ischemia. So you look for ischemia when there is a biliary stenosis, and again you can have the dilatation for this stenosis if you see it. And so by ultrasound you look for dilatation. If there is dilatation, you can do cross-sectional imaging and you see what's the cause. For here there was this large fluid collection that is causing compression, and you can actually do some stenting, biliary stenting, to relieve the stenosis if there is a stenosis proven by MRCP after further evaluation, like what we do here. There can be some biliary necrosis secondary to combined, biliary stenosis and ischemia, and you see multiple areas here of necrosis along the course of biliary tree. There is also graft rejection, which is most common cause for graft failure. Imaging is very non-specific. So if you see, abnormal RI with heterogeneously looking liver, some abnormal echogenic liver, you can think of it. So we can have also some tumors like post-transplant lymphoproliferative disorder, like what you see here with significantly enlarged lymph nodes. Or you can have recurrent neoplasm in the liver itself. And you can have some infections such as abscess and some collections such as hematomas. You can use the nuclear medicine like HIDA scan if you suspect a biliary leak. So again, when look for liver transplant, look for the you know, what are the components of my imaging? You have vascular, arterial, and venous. You use the RI, you use the color Doppler, and then you further evaluate it by contrast cross-sectional imaging if needed. You can look at the biliary, and if there is dilatation on ultrasound, you can further evaluate it by MRCP, and biliary ischemia is the most common cause for, you know, biliary stenosis. So this is another thing that you look at and evaluate, and they can go ahead and stent the bile. You look at the parenchyma, and which is another component. Look for infarctions in the parenchyma. You look for recurrent neoplasm, and then you look outside for post-transplant lymphoproliferative disorder. Again, have the thought process, and of course the most common one is the fluid collection, and the most concerning of them is bile leak. And bile leak you can evaluate it by HIDA scan to actually detect the leak, or another thing which is hepatobiliary contrast agents. I have to finish here. Thank you very much for because I might be beaten.
Thank you.
Thank you.
Thank you, Dr. Khalid. It was, as usual, an outstanding presentation. We are enjoying your lecture too much, but I know it's long topics, and due taking of time, we have shortage. So I don't think there is any time for any questions, but because in the afternoon session, we will have time, and we will keep the questions for the afternoon.
So there is one session afternoon?
Dr. Masleh, 1:30.
1:30?
Yes.
We'll come back at 1:30?
Yeah. Thank you for everybody. Thank you.
So I'm going to talk about MRI and CT of the gallbladder, and this is an unusual topic, and the reason it's unusual that most people are just satisfied with ultrasound, and they just do ultrasound. I'm saying MRI and CT of the gallbladder. Would I say that, you know, I replace ultrasound by MRI or CT? I wouldn't say that. I would just still say that ultrasound is the diagnostic modality of choice for diagnosing gallbladder disease, and MRI is used as a problem-solving modality. I'm going to go over some cases first, and then, you know, talk about them. This is case number 1. So what's happening here? So this is pre-contrast, and this is 20 minutes after contrast, and the contrast here was obviously EUVEST or PrimoVest, and this is hepatobiliary contrast agent. So what's the diagnosis? Yes. Case number 2. Case number 3. Case number 4. No, that's number 3 still. Case number 4. Case number 5. Case number 6. 7. 8. 9. 10. 11. 12. 13. 14. 15. 17. 19. 20. So MRI imaging of the gallbladder cases I showed you is just something to refresh our minds, and then we'll go forward when see these cases as we go through the lecture. So So those are the learning objectives. So why MRI? I'm again saying real-time ultrasound is the most widely used, most widely accepted diagnostic modality of choice for gallbladder disease. But why MRI? Because MRI, with increasing use of MRI and MRCP, you still can see gallbladder pathology, can be frequently seen. You need to characterize them, so you need to be aware of the basic patterns of various disease manifestations and the appearance for an MRI, which is a key to make an accurate diagnosis, and that's why we should be familiar. MRI also is used as a problem-solving modality. This is a case by ultrasound. We see lobulated echogenic structure in the gallbladder fundus, and we see some vascularity within the structure. So would be concerned about a pathology like that on ultrasound. What would I do? Would I do MRI or CT? I'll show you why we do MRI rather than CT. But by MRI, it demonstrates that this lobulated looking echogenic area within the gallbladder is just like a layering, hyper intense material on T1, that's hyper intense on T1, low signal intensity on T2, and this is post contrast is still hyper intense, but does it enhance? We need to do subtraction. It doesn't enhance on post contrast T1, so this is a sludge, and this is where it shows that this is not a mass, this is just a sludge. And thermofactive sludge can show some twinkling, which can mimic some vascularity. But why not CT? This is proven by papers that MRI and MRCP is way more sensitive and specific than ultrasound and multi-detector CT in evaluating biliary system and detecting calculi. This is a gallbladder packed by calculi, as you can tell here. Multiple small calculi, packing the gallbladder lumen. What by CT? You don't see any of them. It's by CT, it's just normal gallbladder, but this is the difference between CT and MRI. CT can really miss gallbladder calculi, which is frequently seen in the gallbladder. This is the MRI technique, so we need to have a mix of T1, T2, fat set and non-fat set, and together with in phase, out of phase, and together with MRCP, which is very necessary in cases of gallbladder disease. This is how we can see the gallbladder. We see it as a low signal intensity on post contrast T1 that's not enhancing. As you see here, you can see the gallbladder wall as a very thin enhancing line. And and this is by in phase, out of phase. It's presumed that the gallbladder the bile within the gallbladder contain intercellular lipid, which demonstrates drop of signal intensity on out of phase compared to in phase. I have to smile for you. So it's presumed that the lack of signal drop on out of phase compared to in phase indicates loss of function of the gallbladder and lack of concentration of the bile secondary to acute cholecystitis. So normally you see signal drop like this on out of phase compared to in phase, but abnormally with gallbladder disease you don't see this signal drop. So lack of signal drop in acutely ill patients suggests acute inflammation due to inability to concentrate bile. This is the MR cholangiogram, which is just delineating the bile ducts by EUVEST or hepatobiliary contrast agents. The hepatobiliary contrast get excreted in bile like this and delineates the bile ducts like what we see now in 20 minutes post contrast MR cholangiogram. And likewise, you can detect bile leak, you can detect gallbladder. Here there is gallbladder perforation. You just waited 20 minutes after injection of EUVEST, and you see this contrast in the gallbladder fossa, delineating the gallbladder fossa secondary to perforation of the gallbladder. And this is where it comes the significance of injection of hepatobiliary contrast agents. This is how you should see MRCP. It has to be nicely reconstructed like that, and you can actually detect the bile as a very high signal intensity relative to intermediate signal intensity of the surrounding liver parenchyma and solid organs. So MRCP is very necessary for evaluation of the gallbladder and biliary tree. It is, you have actually as a radiologist an evaluation of gallbladder to really detect the anatomy, the bile anatomy. And there is a case, this is, for example, it's apparent insertion of the right hepatic duct, as you see here. It should be inserted higher up here. It should be just bifurcated here, but it's inserted lower down in the common bile duct, and this is cystic duct which is very close to it. So what happened is that this can be ligated with the cystic duct at the time of cholecystectomy. So we need to pay attention to that anomalous variation of the bile duct insertion. So we need actually to document in this during interpretation, because this can lead to a significant problem and inadvertent ligation. This case was referred to me in the University of Michigan when I was in University of Michigan, and it demonstrated this as a mass. And they say, okay, evaluate liver mass. And actually, I'm not going to take very long time on it, but this is actually not a mass. It's just packed, dilated tubular structures in the right hepatic duct. The right hepatic lobe is almost entirely atrophied, and the left hepatic lobe, this is all the left hepatic lobe which became hypertrophied, and this is actually secondary to ligation. Here you see this is both the cholecystectomy clips, and what happened at surgery is the surgeon and the radiologist, actually I'm not sure whether there was MRCP before surgery, because that's not the standard of care to do MRCP before surgery. So the surgeon actually missed this anatomic variant of low insertion of the right hepatic duct, and he ligated the bile duct at surgery, which led to atrophy of the right loop and significant dilatation and crowding of the bile ducts within the atrophied right hepatic loop. And actually those are the post-cholecystectomy clips. On MRCP, you see how it's low inserted in the common bile duct. You see how the right hepatic duct is low inserted in the common bile duct, and this is like artifact secondary to the post-cholecystectomy clip, which actually ligated the anomalous right hepatic duct. So you need to be aware of the biliary anatomical variants that can lead actually to significant inadvertent ligation of the bile ducts. You need to be aware also of other congenital anomalies such as agenesis and duplication. Those are very rare, but you might actually be incidentally seeing them. This is a case of agenesis of the gallbladder without history of prior cholecystectomy, and you don't see any gallbladder. In such a case, this was agenesis of the gallbladder. Now again, when I actually go over any organ, I try to come up with my own approach, and the patterns here of the gallbladder, I said, okay, let me evaluate it from outside inwards. Like, so I look at the wall first, and I have some if I have some wall thickening, I characterize it as uniform, non-uniform, or just a focal polyp. I see whether this is distended, the gallbladder itself is distended, then the wall thickening. Then if there is some manifestations within the wall, then I comment on the intraluminal contents, and then I see whether it's involved by diffuse processes. And as I said, again, wall thickening can be smooth, uniform, diffusely dilated, diffusely thickened, or it can be asymmetrical, focal, non-uniform, or there can be a polyp arising from it. Wall manifestations, there can be gas, calcifications, cysts, hemorrhage, sloughed mucosa, intramural nodules. So the patterns of disease involvement: grossly distended gallbladder, a polyp, as I said, and wall thickening, and then intraluminal content and diffuse processes. This is case number 1, and where there is a grossly distended gallbladder, and it's like the small bowel. There is mechanical obstruction, there is adynamic obstruction, or physiologic dilatation. So here you can see a calculus, and this calculus is impacted within the cystic duct, and it's compressing on the adjacent common hepatic duct, okay, and causing significant intrahepatic biliary ductal dilatation and dilatation of the gallbladder. This is what's called Merisi syndrome, and the patient can be acutely presenting with right upper quadrant pain. And again, you see the calculus occluding the cystic duct, and by means of mass effect and by means of inflammation, there is compression on the common hepatic duct, leading to dilatation of the gallbladder and intrahepatic biliary ductal dilatation. So this is pattern number 1, which is grossly distended gallbladder, and it's like the small bowel. It can be dynamic or adynamic, can be mechanical and physiologic. And the mechanical one can be like this Merisi syndrome, or can be like just a calculus occluding the gallbladder neck. So Merisi syndrome is gallstone lodged within the cystic duct, leading to inflammation, focal wall thickening, compression of the common hepatic duct with resultant secondary intrahepatic biliary ductal dilatation, leading to jaundice, and could also present with right upper quadrant pain. This is grossly distended gallbladder without a mechanical obstruction cause, and this is with the gallbladder hydrops, which is seen in patients, diabetic patients with impaired smooth muscle function or defective neuroendocrine mechanism, chronic cholecystitis, cirrhosis, and diabetes. So systemic condition can lead to gallbladder hydrops. HIDA scan can confirm diagnosis by lack of excretion of contrast into the gallbladder. So we move into the gallbladder wall, and whenever we see uniformly, diffusely uniform distended gallbladder, we can have also our list of differential diagnosis. And here there is a case of significant distension of the significant thickening, which is uniformly involving the gallbladder wall, some edema within the wall itself, and then in the liver there is some pericholecystic enhancement, and then you do MEP, maximum intensity projection, and the reconstruction of the bile ducts. You see a small calculus impacted in the cystic ducts, and this is acute cholecystitis. So most important cause of diffusely thickened gallbladder wall is acute cholecystitis, and this can be made also, this diagnosis can be made by ultrasound. And then you have chronic cholecystitis, which is also diffusely thickened wall. Some enhancement, yes, but much less than in cases of acute cholecystitis, because it's a chronic case. As you see here, this is just diffusely thickened gallbladder wall, some subtle enhancement of the mucosa, no pericholecystic enhancement. So you don't see pericholecystic enhancement like in cases of acute cholecystitis. This is much more common, setting than acute cholecystitis. And then you can see diffusely thickened gallbladder wall in cases of, systemic or hepatobiliary diseases, such as in this case with cirrhosis and large amount of ascites, leading to secondarily, thickening of the gallbladder wall. So you can see secondary thickening, secondary to systemic or hepatobiliary disease, and you need to correlate that with, again, underlying disease. So this is uniformly thickened gallbladder wall. What about if there is some manifestation within these within this entity of diffusely thickened wall? This case I showed you in the beginning of the lecture, and there is air dissecting through the gallbladder wall and present intramurally, and this is diagnostic of emphysematous cholecystitis. This is a worse, subtype of acute cholecystitis that has a worse prognosis than the standard acute cholecystitis, and it can be seen in diabetic patients, and you need to actually raise a flag when you see such a case, because it has a worse prognosis than the standard acute cholecystitis. These cases are treated by emergent cholecystectomy and IV antibiotics. What about calcification? Like in this case here, you see some, diffuse smooth calcification. The gallbladder wall manifested by low signal intensity on T2, low signal intensity on T1. By CT, this is one of the, a few cases that CT can be more diagnostic than MRI. You see diffuse calcification. So CT can be better with presence of calcification or air within the gallbladder wall. So this is another sign, a diagnostic sign that actually is pathognomonic to a certain entity. This is porcelain gallbladder. The significance of porcelain gallbladder is that it's predisposing disease to gallbladder adenocarcinoma. So again, this is porcelain gallbladder. What about if you see hemorrhage within the gallbladder wall itself? You can see hemorrhage like where we see here, high signal intensity on T1 and high signal intensity on T2. This is definitely a blood signal intensity, and again this is hemorrhagic cholecystitis, and you can see this in subset groups of patients with diabetes, and again it also has worse prognosis than the standard acute cholecystitis and need to be emergently taken care of. This is a sloughed mucosa, so again you see diffusely thickened wall, but you see some sloughing. You see sloughing of the mucosa here, and you see that in cases of gangrenous cholecystitis. Again, the most important thing with these cases like gangrenous and emphysematous cholecystitis is that the patient on ultrasound will lose sonographic Murphy's sign, because they lose the nerve supply for the gallbladder, so they cannot actually manifest with right upper quadrant pain, but the patient will have debilitated condition. Again, this has worse prognosis than acute cholecystitis and need to be emergently taken care of. So gangrenous cholecystitis, and there is here sloughing of the mucosa indicative of gangrenous cholecystitis. What about if you see cystic looking lesions here within diffusely thickened wall, like what we see here? There's multiple small cysts, okay, and they can actually have some enhancement of the mucosa, like what we see here. This is a case of adenomyomatosis. You need to make this diagnosis and don't mix it, don't confuse it with other entities. This is a benign condition. Don't touch. You don't need to do anything about it. It's just a benign condition that you need to actually diagnosed by ultrasound. Can have comet tail artifact, echogenic foci with comet tail artifact, and by CT it can be as bad as this. It can be significantly thickened gallbladder that can mimic other entities. So adenomyomatosis is a benign condition characterized by excessive proliferation of epithelium within the mucosal outpouch. It's like divertically, like intramural divertically, and that's what they call it, Roktansky-Ashhoff sinuses, and can be diffuse, segmental, or localized. And the most common location for focal involvement is within the gallbladder fundus, like what we see here. This is something you need to make, because some people can mix this with more concerning entities, especially with ultrasound. What about, so we went over diffuse gallbladder wall thickening, we went over some signs within the gallbladder wall like gas, calcification, cysts, sloughing of the membranes. What about non-uniform gallbladder wall thickening? Like what we see here, we see some area. I mean, the gallbladder is, yes, diffusely thickened, but some areas are more thickened, like here, more than others. So this case was actually xanthogranulomatous cholecystitis. So some forms of chronic cholecystitis, such as xanthogranulomatous cholecystitis, can lead to non-uniform diffuse wall thickening. There can be even, this can mimic even cancer, because there can be loss of fat planes between the gallbladder and liver, and can be some small intramural abscesses within the wall. Like what we see here, there are some small abscesses within the gallbladder wall. And here again you see also again non-uniform gallbladder wall thickening. You see thickening that's more actually into one part of the gallbladder wall, and this was actually proven case of gallbladder carcinoma. So the patterns of involvement of gallbladder cancer, patterns of disease, is just the most common one is a mass replacing the whole gallbladder, or can be diffuse or focal thickening of the gallbladder wall, or there can be also polypoidal mass within the gallbladder lumen. This is again non-uniform gallbladder wall thickening, like what we see here in the fundus, and it's associated with other hypo enhancing foci in case of gallbladder lymphoma, and which can rarely involve the gallbladder and lead to non-uniform or focal wall thickening. What about polyps? And we're moving now to another pattern which is a polyp. Most of the polyps are benign, and most of them tend to be like small, like less than 1 centimeter, and pedunculated like this. If you see a pedicle like that and a small gallbladder size like that, you actually need to think of benign gallbladder polyp. When you see gallbladder polyp, you need to evaluate for two main things. Like how the polyp looks like. Is it pedunculated? Does it have a pedicle? Or it has a sessile base? And the other thing is, what's the size? Is it more than 1 centimeter or less than 1 centimeter? Most of these are benign. The polyp like that is likely benign. I don't actually see any reason for even following this up. But a polyp like this one, this is actually a bad polyp. It's a sessile. It's not like a pedunculated one. It doesn't have a pedicle here. It's sessile and it's larger than 1 centimeter. We followed this up and we found it increasing in size. In 6 months follow-up, this was resected and was surgically proven to represent gallbladder carcinoma. You can also have a polyp like this. This is a mass that's seen within the gallbladder wall, and this represented gallbladder melanomatous deposit. This is a case of renal cell carcinoma that actually resulted also in polypoidal-like enhancing mass in the gallbladder secondary to the gallbladder cancer. So metastatic deposit can be also another reason for polypoidal mass within the gallbladder wall. What about diffuse processes involving the gallbladder? We have main differential here. The main differential for me is gallbladder adenocarcinoma, which is like this case. You see a mass infiltrating the gallbladder and engulfing it with multiple like calculi engulfed by this mass. This is a case of gallbladder carcinoma. This is the most common pattern actually of gallbladder cancer. Again, you see a big mass like that, mass that's faintly enhancing some calculi within, and the gallbladder is not even seen because it's infiltrated by this large mass. This is gallbladder carcinoma. This is a gallbladder rupture rather, and it's a diffuse process too. You just see an area of low attenuation. The most specific sign for diagnosing gallbladder rupture, as we see here, is the presence of a calculus within the collection, adjacent to the gallbladder. So when I see something like that, I see a gallbladder calculus here in this collection, I would actually specifically make a specific diagnosis of gallbladder rupture with an adjacent collection within it and with a calculus seen within the collection. Nice. 5 دقايق بالظبط. خلي بالكم المودريتور will come and tell me 5 minutes. And I'll make a great achievement of finishing on time within 5 minutes. So the diffuse processes here is, as I said, in cases of gallbladder cancer, and here the rupture of the gallbladder, and there are some types of rupture, but the most important, as I said, the most specific sign is presence of calculus outside the gallbladder, like what I see here. So another diffuse process here, this is a multiloculated. Remind me of the liver case, multiloculated septated mass. Remember that biliary cyst adenoma is a biliary tumor, so it can occur in the liver or biliary tree, including the gallbladder. This was a biliary cyst adenoma involving the gallbladder. So this is diffuse processes, again, biliary cyst adenoma, and I already talked about it in the liver lecture. So we move into the intraluminal content, and normally it should be of low signal intensity on post-contrast T1 and very high signal intensity on T2. Here, this is T1, which actually demonstrates a very high signal intensity on T1, low signal intensity on T2, and you know that this is blood signal intensity. When blood is diagnosed within the gallbladder, it's likely due to bleeding bathes, bleeding tendency, and use of anticoagulants like heparin. And actually hemorrhage also can have the same signal intensity like sludge. It can be just full of large amount of sludge. So you need to correlate with history of anticoagulant medication. Here in this case, I made the diagnosis here of biliary enteric fistula. You see a focus of gas here just from the intraluminal content. There is something here wrong, which is the presence of gas within the gallbladder lumen. It's worth noting that there can be gas containing calculi within the gallbladder, but this one, I followed this. You see this extra anatomical tract containing contrast. This is actually joining the first part of the duodenum with the gallbladder. So this is cholecystous to enteric fistula, and I proved this by MRI. If you follow, you see this enhancing tract between, extra anatomically between the gallbladder and the duodenum. And then again, intraluminal content, you can have biliary enteric fistula. But the more common one that we actually, not the more common, but the more showing in exams is what? Gallstone ileus, when you see significant small bowel dilatation. So what happened here is there was inflammation without calculus that lead to fistula, okay, or a calculus has just passed with the stool. But this one, there was a calculus, large calculus, there is a gas here, secondary to the fistula, but there is significant dilatation of the small bowel, and the calculus is lodged here within the small bowel, and this is a triad of pneumobilia here. So you see here the air within the biliary tree, and the significant small bowel dilatation, calculus lodged within the small bowel. This is gallstone ileus. The calculus can be lodged within the gastric outlet, leading to gastric outlet obstruction, and that's what's called Bouvray syndrome. Bouvray syndrome is a calculus, biliary enteric fistula. There was a calculus in the gallbladder. It went to the gastric outlet, completely occluded it, leading to Bouvray syndrome. Gas can be, as I said before, gas can be like a gas containing calculus within the gallbladder lumen, like what we see here in such case here. This is just a gas secondary to a calculus within the gallbladder lumen. Calculi are easily diagnosed by MRI as of low signal intensity, against contrasting with the high signal intensity on T2. So again, to comprehend, there is 1 minute left for me. I'm going to be achiever here. So the patterns of involvement is wall thickening. When you start from the wall, you have uniform wall thickening, and differential would be acute cholecystitis, chronic cholecystitis, or secondary to biliary or systemic disease. Non-uniform, then to granulomatous cholecystitis, cancer, and lymphoma are the most common patterns of differential diagnosis. And then you look into the wall and see whether there is certain manifestations within the wall. If you see gas, this is pathognomonic for emphysematous cholecystitis that has worse prognosis than acute cholecystitis, need to be emergently taken care of. Calcification, porcelain gallbladder need to be resected because of the risk of developing gallbladder adenocarcinoma. Cysts don't touch, like if you see small cystic lesions, areas within the gallbladder wall is diagnostic of adenomyomatosis, which is a benign don't touch condition. Hemorrhage secondary to hemorrhagic cholecystitis, which is the same like emphysematous cholecystitis. It's worse prognosis than acute cholecystitis, tend to develop with diabetic patients. And then sloughing of the mucosa in case of gangrenous cholecystitis. Then you can see some intramural nodules with densogranulomatous cholecystitis. Grossly distended gallbladder can be secondary to hydrops, which is amechanical or adynamic, and mechanical obstruction secondary to Merizi syndrome or any calculus impacted within the neck. The polyp, you need to differentiate between the benign and the malignant. I wouldn't say that, if it's above 1 centimeter and the sessile base, it's malignant. I wouldn't say that. I would just say that it needs follow-up, because also a significant proportion of them are benign. But 1 centimeter and sessile base would raise a flag of suspicion, or at least a follow-up, need for follow-up, and need for to be concerned about it. And then the intraluminal content should be homogeneous, low signal intensity on T1, high signal intensity on T2. I mentioned some cases where it can be otherwise. And then diffuse processes, you need actually to look into the gallbladder cancer. Gallstones are commonly seen with gallbladder cancer. It's not like you see gallstones, so it's not cancer. No, actually it's commonly seen with gallbladder carcinoma. Gallbladder carcinoma can be seen as mass infiltrating the gallbladder, non-uniform gallbladder wall thickening, or a polyp that's larger than 1 centimeter and has sessile base. And then you remember the rupture and the biliary cyst adenoma. I hope this pattern approach would be useful, and it was a great pleasure of being around you here. It was a great honor, wallahi, and I really feel the honor and love to the city of Prophet Muhammad sallallahu alaihi wasallam. I feel the neighborhood. I feel that I'm across the street from the Prophet Muhammad sallallahu alaihi wasallam. This is a great honor, alhamdulillah, and we should be all proud of this, and we should be all happy of being around here. Jazakumullah khairan for inviting me. I would pay money to come here and really see my brothers and all of my friends and sisters and colleagues. Jazakumullah khairan. May Allah Azza wa Jalla raise our ummah and make it the best ummah. Kuntum khayra ummatin ukhrijat lin-nas ta'muruna bil ma'ruf wa tanhauna 'anil munkar. Wa jazakumullah khairan.
Thanks a lot, Dr. Khalid for excellent lectures and excellent review for such important topics. I think we'll conclude, we'll move to the next session. Thanks all.
خالد السيد أستاذ في أشعة في مركز MD أندرسون للسرطان بجامعة تكساس. أنا سعدت إن أنا أشوف التجربة الرائدة بتاعت مركز طيبة للكشف المبكر. طبعا دي حاجة جميلة جدا، لأن ده يعني هم يعني أخذوا المبادرة إن هم يتحركوا بنفسهم للمرضى أو بصفة عامة لعموم الناس، إن هم من أجل الاكتشاف المبكر للأورام. وده حاجة طبعا عالمية، يعني أصبحت مثل الألف والباء، يعني أصبحت أمر مسلم به في العالم كله. هو حتة إن هو مسألة الفحص الدوري للاكتشاف المبكر للسرطان في كثير من السرطانات، ويشتمل ذلك على سرطان الثدي اللي هو بداية من 40 عام. يجب دوريا وسنويا أن المرأة تعمل فحص دوري على ثديها لاكتشاف أي ورم مبكر، وده في حالة اكتشافه في مرحلة مبكرة بيؤدي لتحسين العلاج وبيؤدي إلى نتائج أفضل للعلاج. فأنا يعني سعيد جدا بهذه الفكرة الرائدة، وسعيد جدا إن أنا أبقى موجود هنا، وربنا إن شاء الله كده يعني يرزق هذه الفكرة النجاح. وأتمنى أن الناس تتفاعل معها، وأن الناس يعني فعلا تتحرك نحو مسألة الفحص الدوري والاكتشاف المبكر، ليس فقط في سرطان الثدي ولكن في كثير من السرطانات، لأن ده بيوفر على الدولة كثير من النفقات. بالرغم من هذا الجهاز يبدو أنه مكلف، لكن مهما كانت تكلفة الفحص وتكلفة الجهاز فهتكون أقل بكثير من تكلفة العلاج في حالة اكتشاف الأورام في مرحلة متأخرة. وأيضا في حالة اكتشاف الأورام في مرحلة متأخرة ده برضو بيخلي فرصة الاستجابة للعلاج ضعيفة، وفرصة الشفاء من هذا الورم أقل بكثير من حالة اكتشافها في مرحلة مبكرة. ألف شكر، وأتمنى التوفيق، وأتمنى إن شاء الله التقدم يعني بلدي الثانية السعودية. والله هو يعني موضوع الفحص الدوري والاكتشاف المبكر أصبح أمر مسلم به، وخاصة في سرطانات مثل سرطان الثدي أصبح يعني حقيقة مسلمة بها، وأمر متعارف عليه، وأمر يعني أصبح أمر طبيعي إن كل امرأة بعد سن 40 بتعمل هذا الكشف السنوي، وفي حالات أخرى قبل سن 40. فده يعني اعتقد ان ده امر مسلم به. ولكن ما يعني اعجبني في التجربه ديت هي ان احنا جبنا السياره وبنتحرك بانفسنا لغايه عموم الناس ولغايه المرضى، حتى ان احنا نقدم لهم الخدمه. وده حرص كبير من زملائنا يحمدوا عليه ويشكروا عليه. فشكرا جدا لهذا الجهد يعني المفروض. خالد السايس أستاذ بجامعة تكساس MD أندرسون للسرطان. شكرا.
Mm-hmm.